Good evening, and welcome to this panel discussion, Opioid Crisis, the Local Response, that has been organized this evening by the Janesville Mobilizing for Change and the League of Women Voters of Janesville. My name is Linda Reinhardt, and I'm president of the Janesville League of Women Voters. I would like to thank the committee of League members and JM4C staff who organized and publicized tonight's program so that many of you, like me, can learn about the scope of the opioid crisis in our community, Janesville and Rock County, Wisconsin, and can also learn what is currently being done and what should be done in the future to cope with the opioid abuse issue in our community. The League's interest in developing tonight's program has evolved out of two main sources. The first is the behavioral health position that was adopted just last year by the Janesville and Beloit Leagues of Women Voters after 2 years of study and discussion. And that position encourages our county board and county administrator to adopt evidence-based policies and practices in regard to individuals with mental illness and or addiction problems and their families. The second reason that the League of Women Voters became interested in putting a program together on this opioid issue is the discovery by the League's Observer Corps, who attend local governmental committee meetings, that several of these local governmental committees were grappling with the impact of the opioid epidemic in Rock County. So when the League was interested in thinking about who in our community has the best resources to partner with us to put together a program for the community on the opioid crisis, the answer was easy, and that's Janesville Mobilizing for Change. So I would like to introduce to you Erin Davis, the director of Janesville Mobilizing for Change, which, as many of you know, is a prevention agency and a department of the city of Janesville. Erin has a master's degree in public administration and has been working in nonprofits and nonprofit management for the last 13 years. In her role with JM4C, Erin manages a number of different county, state, and federal funding sources that focus on prevention of alcohol and drug use in youth. In addition, Janesville Mobilizing for Change provides staffing for the Rock County Prescription Drug Abuse and Heroin Task Force, of which Erin is the chair. So without further ado, I'd like to introduce Erin Davis.
Thank you very much, Linda. Thank you guys all for coming today. We really appreciate it. Hopefully you will learn something that you didn't know before and be able to take away some interesting and hopeful messages about what is going to be coming in the future. Before I begin, I'd like to let you know that many of you received an index card. And if you didn't receive an index card and would like one, we have 3 volunteers in the room that have them. The index cards are for questions. Towards the end of all of the presentations, we will be turning the index cards in, and then we'll be taking questions off of that. If there are any questions that we don't get to based on the size of the room, then what we'll be doing is that on Monday or Tuesday, we will be posting the answers on Facebook. It'll go first to the JM4C page, and we'll share it with the League of Women Voters page so that you can see those responses. All right, so why are we here? I mean, locally, Linda explained to you what it is going on here in Rock County that made us think that we wanted to have a panel. But across the nation, we've seen huge increases in the number of opioid overdoses, the number of opioid deaths. From the year 2000 to the year 2016, the opioid overdose death increased by 330%. When I did the math, it was actually 333.3 to the infinity degree in the number of deaths that there were. So prior to the year 2000, we had 3 cases per 100,000 Americans, and currently we have 13 cases per 100,000 Americans. That number is more than 42,000 people that have been confirmed as having passed because of the use of opiates. And one thing that I would like to mention is that when we speak about opiates or opioids or carfentanil, heroin, methadone, these are all part of the same drug classification that people are overdosing on our streets every day. The symptoms of overdose can be mistaken for a number of other different causes of death. Some of those would be heart attack. There's lack of breathing when somebody is overdosing. It could be confused with another drug that somebody is using. And I think that the accurate depiction that we're getting now more than ever is really helping us to understand how big the problem has gotten. The local impact. So nationally, we know that from 2015 to 2016, the increase in overdose deaths was more than 17%. Now here in Rock County, or I'm sorry, here in the state of Wisconsin, the increase was 24.5%. Did I have that right? I can't see it. Okay. Wisconsin had the 15th greatest increase throughout the United States. That's based on 51 locations, including Washington, D.C. Washington, D.C. itself had the greatest increase in the U.S. of more than 100%. So that number is very staggering. The overdose rates showed a 30% increase, and the next number is very alarming, and that is that in the state of Wisconsin, the overdose rates increased by 109%. This 109% pulled up the Midwest average, and therefore the rates in the Midwest were more than 60%. I believe it was 69% increase, and throughout the other regions of the United States, the increases were less than 40.3%. One location had an increase of less than 16%. So you can see that right here in the Midwest, we're really struggling, and here in Wisconsin in particular, the struggle is great. And one thing to point out is, when we talk about overdose, that doesn't necessarily mean that somebody passed from the overdose. You can be revived from an overdose with the use of Narcan, and so the overdose rate is much higher than the overdose death rate. So right here in Wisconsin, how do we compare in Rock County to the rest of Wisconsin? To begin with, one of the statistics that we like to discuss is neonatal abstinence syndrome. If anybody is unaware of what this is essentially when a child is born addicted to heroin. The withdrawal from heroin for an infant it's just as terrible as it is for an adult. They require special services right from birth. In some cases, they may be hospitalized for great periods of time. Other infants can go home or to a foster family within a shorter amount of time. Throughout the state of Wisconsin, there was a decrease, an 8% decrease in the rate of neonatal abstinence syndrome. However, here in Rock County, we saw a I can't see my numbers. We saw a 28% increase in the number of neonatal abstinence syndrome cases. We went from 12.9 to 16.5. So very shocking and very unfortunate. Our opiate overdose death rate is 14.3%, or 14.3 cases per 100,000 individuals. This is the same as the rest of the state of Wisconsin. So we are at about the state average for that. One of the things that I was looking at and found when I was doing research for this was that Wisconsin comprises 4% of the overdose deaths in the state of Wisconsin. And while 4% doesn't sound like a great deal, it's important to note that the population of Wisconsin is only 2.7% of the population of Wisconsin. Population of Rock County is 2.7% of the population of Wisconsin. So we have a disproportionate number of overdose deaths in our county. So what does that mean? couple years ago, we were named a high-intensity drug trafficking area by DEA, the Drug Enforcement Agency. And part of the reason for that, I put a map of Rock County up here. You can see Janesville's right in the middle. We have Beloit at the bottom, and we have two different interstates that run right through our county. Unfortunately, the presence of an interstate in our county also means that we have an increased number of drugs that move through because they travel easily on the interstate. We also have to the north Madison, Minnesota. Minneapolis is right along the interstate there. To the east, we have Milwaukee, and to the south, we have both Rockford and Chicago. So these are places where drugs are frequently coming from. And with that, I'd like to introduce our featured guests. First, we'll have Brandon Cook. Brandon is a person in recovery. He is local from the city of Edgerton. He spoke last week at a panel up in Edgerton, did a fantastic job, and he'll be telling us about his story tonight. After that, we'll be hearing from Officer Dan Schoonover, and he will be telling us about the efforts by the Janesville Police Department in the battle against the opioid epidemic. Following that, we'll hear from Brenda Endhoff. She is the AODA coordinator for Rock County Human Services. She runs the walk-in clinic and is also a major part of the heroin task force and is the JM4C contact for the county contract. And then we'll be hearing from Sarah Bradley. Sarah works for DISPIS, which is the Department of Safety and Professional Services. And DISPIS runs the statewide prescription drug monitoring program, which keeps track of all of the medications that are prescribed and given out by doctors and pharmacists. So without any further ado, we'll have Brandon come on up.
It's really nice to be here tonight. Like Aaron said, I'm from Edgerton, originally from Edgerton. Been in a few other places, but I'm back now, and it's really nice to be here tonight in this community. Growing up here in this area, this Rock County area, it really means a lot to me. So hopefully sharing my story can help some people. I really hope that it will. I'm going to begin my story way before I ever started using drugs, because I think it's important to understand how a seemingly normal kid from a small town could fall into such a horrible cycle of self-abuse. I was always a very good student, mostly A's and B's. I played sports all through school and participated in all the normal teenage things. After I graduated from high school, I went on to attend the University of Whitewater. I felt like my life was on a track, just not necessarily the one I wanted to be on. In my second year at Whitewater, I started to develop a crippling social anxiety. I could do the homework and the projects, but I found it very hard to leave my apartment to attend classes. The only thing I felt comfortable with was drinking and making other people believe I was doing great. My first experience with opiates came at a party while I was in school at Whitewater. A friend of mine gave me a pill called OxyContin, and basically from that moment I was hooked. I remember telling myself that this was the thing that could fill the hole you have inside you. It helped me relax, it helped me be more social for a time, and it also numbed me into oblivion. At that time, I would take a pill once or twice a week. In my head, that was okay because it was just a pill. I grew up in a time where people didn't really fear pharmaceuticals. If a doctor had prescribed it, it had to be a good thing, even if it wasn't necessarily prescribed to you. Although I thought OxyContin was the answer to all of my problems, eventually even the pills couldn't get me to class, home to see my parents, or even out to see my friends. I was completely lost at the end of my third year of school in Whitewater, so I did the most logical thing I could think of. I quit school and moved to Milwaukee. At the time, I saw it as a fresh start and a way to try something new, but frankly, I was just supplanting myself closer to the drug I loved. When I got my first apartment in Milwaukee, I lived exactly 2 blocks from my OxyContin dealer. I could no longer go more than a day without buying at least one pill just to get me through. My addiction had grown so rapidly, it had completely taken me by surprise. I had no idea that the pain in my legs, the sweating, the racing thoughts had all come from the overuse of this drug that I loved. I searched for ways to stave off the withdrawal symptoms so I could go to work, make money, to buy more pills. The expense had outgrown the addiction. I could easily spend between $300 and $500 at a time with no regard for how I would eat, pay rent, or put gas in my car. The voice in my head that kept telling me I needed more and more got stronger and stronger every time I woke up in the middle of the night in agony going through withdrawal. Among the few friends I had made in Milwaukee, the idea of trying heroin became more prevalent. The cost of buying pills had become so unmanageable that the only way to maintain the lifestyle was to cross that invisible line. A few years prior, the notion of taking heroin would have been abhorrent. Opiates had dug their claws in deep, and for most of us, we had pushed that invisible line a little further back. For most of you that don't know, heroin is way cheaper than pills, and in most cases, it can be way more potent. The danger lies in that potency. Heroin is generally cut with other products meant to make it last longer and sold into smaller quantities. This mix is what causes overdoses and deaths among the addicted. I experienced my first overdose within just a few months of trying heroin. The slight amount of caution I had taken in my decision to use heroin had given way to a general uncaring for my own well-being. These events coincided with a close friend of mine choosing to end his own life rather than continue the daily battle with addiction. Suddenly, the dangers of the lifestyle I had chosen to lead were becoming very real. It had never really occurred to me that I would become an addict when I was taking a pill here and there back in college, but then I became an addict. It never crossed my mind that I would lose a friend due to drug use, but then my friend died. I certainly never considered I would be on the verge of homelessness, completely broke, but then I found myself stealing food from the grocery store down the street. Within a few years, I had fallen hard. I had been able to maintain a job for much of the time I had been living in Milwaukee, but the paychecks were going directly into maintaining my habit. On average, I was roughly spending between $75 and $200 a day on heroin. I didn't pay any of my bills, rent, or even food. I begged, borrowed, and stole anything I could get my hands on. Nothing and no one was off limits. I stole repeatedly from my parents. I took one of my mom's checkbooks, and every day that I needed extra money, I would just write myself another check. I did the same to my grandparents. I did this to the people I loved the most. Had I asked them for help or told them what was going on, they would have done everything in their power to help me. I continually burned the people closest to me. My life had become complete insanity. I was depressed, guilty, and ashamed. Finally, after 4 years in Milwaukee, my landlord served an eviction notice, and the next day I called my dad and asked me to bring me home. He picked me up just like he promised he would. When he looked at me, I could see the pain I had caused him and my mom over the last several years. I stood before him with a couple of duffel bags, emaciated, maybe 120 pounds, soaking wet. I remember he took me to Pizza Hut right before we went to the Rock County Crisis Center. I could barely eat anything, but I think he really just wanted to make me feel better, and feeding me was the best he could do at the time. Later that day, we found out the detox center didn't have a bed available to opiate addicts, so I had to tough out the withdrawal symptoms on my parents' couch. I know it must have been horrific to watch me in agony for nearly a week, but they helped me as much as they could until the detox center called with an open bed. Detox did a lot for me. I felt like I had a new chance to do something with my life. I stayed with my parents over the holidays. I got to watch the Packers win the Super Bowl. My parents took me to an outpatient therapist for drugs and alcohol. After a few months of being cooped up in the house, I felt like I really needed to get a job and try to get my life back together. I started working at Stoughton Trailers a few months into my newly found sobriety. At first, the work was hard, but a positive influence on my life. I met a girl named Jessie at a house party, and soon after, we started dating. I felt like things were really starting to come together for me. Within a few months of work, I started to make some bad decisions. I made up excuses to skip my therapy sessions. I started going out with friends and drinking. I never had much of a problem with drinking, so I felt it was a safe environment. Some familiar patterns were starting to emerge. I was replacing heroin with alcohol, and instead of going out on the weekends, it became the weekdays. I'd also met some people at work that were able to get their hands on pills. I told myself I could do it, no problem. I relapsed. It wasn't just a little relapse, it was a full-blown right back to the old habits, lying, cheating, stealing relapse. The only difference this time was I was arrested. All those years living in Milwaukee, never once got arrested for anything seriously illegal. Soon after my relapse, I was sitting in a Milwaukee County jail booked on felony possession charges. I had never been in trouble before, and with a felony hanging over my head, I felt as though my life was over. Jessie got me out of jail and home. She tried to get me back into a detox facility, but just like the first time, everything was booked. I didn't care about anything anymore. I bought some heroin for what I thought would be the final time. I intended on overdosing and ending all the pain for me and those around me. As soon as Jessie had realized that I had gotten drugs and had overdosed, she called the police. I couldn't imagine how hard that must have been for her, but she saved my life that night. The Edgerton police took me to the emergency room where I was given Narcan. Narcan is used to reverse the effects of opiates, especially in an overdose situation. For me, it was like being wrestled from a bad dream and into reality. This is where my legal troubles could have doubled. But instead, the police noticed that I was someone who needed help, not jail. Nearly 6 years ago, I was sitting in a clinic waiting room in downtown Janesville, fielding questions and filling out paperwork to enter a residential drug treatment program. It was called AlcoCare, no longer exists today, but I was there for 30 days of treatment, and it was everything I needed at the time. It gave me the tools to understand my addiction and how to keep myself sober for life. I had support from my parents, Jessie, and other friends. Residential treatment worked for me because it removed me from the daily drug-seeking ritual. We attended AA and NA meetings, met with other people in the community that were sober and working daily on staying sober. I had the time to think about the choices I was making and who they were ultimately affecting, and the changes I wanted to make. When I got out of treatment, Rock County set me up with a psychiatrist who I still see to this day. I credit a great deal of my sobriety to the people I have met at the Janesville Counseling Center. My doctor suggested I try a drug therapy called Suboxone. Suboxone blocks the opiate receptors in your brain. This made it impossible to feel the effects of heroin or other opiates. Suboxone gave me a little piece of freedom from my addiction. For the first time in years, I felt like I was no longer beholden to the drugs. I could focus on finding a job and having meaningful relationships with positive friends and family. So Jessie and I ended up moving back in with my parents for what I hoped was the last time. Nothing about being clean and sober was easy for that first year, especially when everyone is looking at you wondering when the other shoe is going to drop. Not that I can blame them. I had given everyone every reason around me not to trust that I would make it through this okay. But then year 2 comes around, and you have your first apartment and a new job. By year 3, I was crazy enough to ask that girl Jessie to marry me. She said yes. Year 4 comes, and we bought a house back in our hometown of Edgerton. I started a great career as an electrician and began training at MATC to become a journeyman in the field. Year 5, she finally gives up and marries me. Then in year 6, I can call my mom and my dad and invite them over for a cookout. When I call them, they don't have to wonder if I'm in a hospital somewhere or overdosed in an alley. I'm not saying that I'm cured or that nobody worries about me anymore. I know I have to work on being sober each and every day. It's hard, but the more reasons I have to continue make it easier and easier. Year 6 will also see an addition to our family. My wife is pregnant with our first child, James, and he is due in June. I can't wait to meet him, and I look forward to the rest of my sober years. Thank you.
You're a lot taller than me. Thank you, Brandon. Next, we'll be hearing from Officer Schoonover. I got it right there, from the Janesville Police Department.
Good evening, everyone. So after hearing Brandon talk there, it kind of like segues well into what we're talking about. A few years back, we had a realization at our department that there was a problem that we were dealing with that we couldn't arrest our way out of. And for any of you out there who know police officers, arrest is kind of part of our job. So we start seeing this growing epidemic. Heroin's becoming a big problem. Pills were always kind of something that we were looking at on our radar. And an officer sat down, Ryan Foster, and offered to come up with a program which he labeled DROP, Death, Recovery, or Prison. And in that moment, we had a shift. We took a problem that we knew we couldn't arrest our way out of and started building a foundation to how to help people. There's a lot of things that have gone into it in the past few years. I'd like to touch on a little bit of that with you here tonight. We don't have a lot of time. Like I told everybody before, this is a presentation that we could give for 4 hours if everybody had the time. So we'll keep it in a 12-minute version for you. All our officers out there on the street, when they get sent to a call and they hear the description of what's going on, in the back of our minds, we all respond the same way. We all think opiate overdose. We look for the same things, the breathing, the color change in the skin. From that moment, officers are responding in life-saving mode. Whether it's chest compressions on scene, we're immediately trying to hold the scene until all our paramedics can get there. All the paramedics in Janesville carry Narcan, naloxone, which is, as Brandon described, a life-saving measure for people who are overdosing on opiate. The danger that we are trying to get across is, and I'm not a doctor, so I'll do my best to explain this to you, heroin and opiates have an effect of about 6 hours, where Narcan has an effect of about 4 hours. So people who are issued Narcan and overdose, self-administer Narcan, 4 hours later come out of it, and they have 2 hours left of this intense high that can kick them right back into an overdose. So there's a big issue that goes along with the training of people when we give them the Narcan naloxone, and I'll let Brenda touch on that probably. But you're not out of the woods. So we have to start looking at more of a forward-thinking treatment option. So from the overdose perspective, once we take that overdose, they get sent to the hospital. I work in our street crimes unit. Someone from our unit usually gets called in so that we can immediately start to talk to the person who's overdosing. We'll build that rapport, let them know they can be comfortable with us. Officer Woodman, who is our drop officer now, he's done a good job of creating this recovery coach program. Every hospital in Janesville now has a card that they can call a recovery coach. And in that moment, we've got a 24-hour recovery coach response program where somebody will come and sit in the hospital room with somebody who's in crisis. They can immediately start to build that relationship, start setting resources, figure out housing, food, what the next step is, which is a big issue for somebody who's just had one of the most traumatic experiences of their life. I can't say I've struggled with the opiate addiction myself, but I can say I've seen it professionally, and I know I'm not the first face that somebody wants to see walk in their hospital room. So it's been very beneficial to have that recovery coach program built. From that point on, we can start explaining to the people in crisis that there are options for you. We're not looking to arrest our way out of this options. We want to build a network, and we want to put a foundation in people's lives where they can have AODA services, they can have other counseling services, they can get treatment for what is the greater disease of their addiction. The Recovery Coach program helps with that. We try to, from the first minute we can in the hospital, put positive things into people's lives. Our officers in my unit especially, we're not secret with the people that we're talking about. We have to go after two forms. Officer Woodman goes after the demand, and we have to go after the supply. We're not giving the dealers a break in this. If anything, we're looking to take their supply away from them. If we can make people addicted go into recovery and 6 years down the road be married and have a happy, healthy family with something to look forward to, eventually we're going to have a lot of broke heroin dealers that are going to be faced with a problem that we all hope is someday in our future. So when we get into that, we try to work with our people in recovery. As Brandon explained, there's lots of bridges that get burned, and usually it's the bridges that are most important to them. So we sit down and we explain to them, bridge burning is a good thing, but let's focus your bridge burning into a different direction. Once we can take bridges out of your life that you can no longer cross, we can help you rebuild the other ones and put them on a more positive path. I can say that in the 2 years that I've been a part of our street crimes unit, there's been a change in how we've seen communication with people struggling from addiction. I'll get daily calls from people who are in crisis, and they're more open with us. They're telling me when they use last, the problems they're looking for. They're trying to get treatment on a regular basis, and we're in constant communication with the clinics and the doctors and trying to get people moving forward. And, you know, there's kind of a running joke that our job has turned more into social work in the past 5 years, but I think that's the answer. If we can't take a more of a social work approach from the perspective of where we're sitting, we're not going to succeed. Because if we keep trying to hit the same direction over and over and over, we're going to fail. So we look to create avenues for a lot of the people struggling with the addiction, the opiate addiction. We know the stats that, you know, we were started off here with tonight with Erin, and they're scary stats. And as she touched on, they're extremely underreported. You know, the numbers that we have, I couldn't even tell you what number you should add to that. I can only give you examples. When I talk to certain people that we come across and we maybe have them on an opiate overdose, we'll ask them, how many times have you overdosed before this was reported? And I've had people tell me as high as 18 in a week. So when we have one person that gets counted as a single overdose, because that's our stat now, is that one single overdose that is telling me they self-administered or had somebody else administer Narcan to them 17 prior times to that one contact with us, you can only imagine what the true number would be. It's kind of a scary thought, but it's the reality we're all faced with. It's kind of all around us. So looking forward, I mean, we have an uphill battle. We know that. We can only hope to continue to build some strong bridges with people. We can hope to build these relationships to the point where we don't have a problem with our phones blowing up at 2 o'clock in the morning. I might not answer it, but if I'm awake, I'll answer questions. I'll get to you in the morning. We have avenues to send people. Beds are still going to be an issue. They're always going to be an issue. But as long as people struggling with addictions are willing to fight for their recovery, we'll fight with them. And that's one of the first conversations we say to them is, I'm with you 50% of the way. I won't work harder than you, but I will work as hard as you. You have to meet me halfway. And we've got 7 guys in our unit that take that same approach with everybody. And I think somebody just hearing that from a police officer kind of shakes them a little bit at first. And, you know, we don't always look for that arrest piece, but that's the last letter of our death, recovery, or prison. So moving forward, when we're talking about how to build relationships, we're building that trust. We're talking to people, open communication. They're telling us what's really going on. We're telling them what's really going on. And in the end, our hope is to continue to move forward down the direction we've made the last 3-4 years or so, and to try to get more people into recovery and hopefully put our dealers out of business one day. So, thank you.
Officer Schoonover. I'm going to bring this back down. Brenda's about my size, so this will work for her. Next we have Brenda Endhoff from Rock County Human Services.
Yeah, we're about the same size. So first of all, I just want to say to Brandon, I've never heard his story before, and that was very powerful. Yep. And hearing you talk about the anxiety that you had that started the addiction and where you've come now, that you're able to do this. And I just have to applaud you again. That's awesome.
Thank you. Thank you.
As Erin said, my name is Brenda. I'm from Rock County Human Services. I'm the AODA coordinator. So I'm going to talk about some of the things that we're doing in Rock County and some of the services that we have that people can access. So the first thing that we have is our AODA walk-in clinic. I hope that everybody's at least heard about this once in your life. The walk-in clinic, we run this 4 days a week. It's Monday through Thursday. We're in Janesville more often just because the volume is more in Janesville. It's from 2 to 4, Monday, Wednesday, Thursday in Janesville. In Beloit, it's 2 to 4 on Tuesdays. So the walk-in clinic is just a basic assessment of needs. So I can't really see my slide that well. So it says that we screen. So we do a basic screening of needs. So what level of care do they need? So Brandon was talking about, he went to residential. He went to detox and residential. If you come to walk-ins, we're going to screen what level of care is appropriate for you. One thing that I really want to pinpoint is when people come in, we understand it is really hard to ask for help. It is super hard to walk in and tell somebody, just a snippet of your story. Like Brandon was saying, he hurt people in his life. And to come in and have to talk about that a little bit and explain why you're sitting in someone's office asking for help, that's very difficult. So we try our best to be warm, inviting. You might come in and people often have the idea that I need residential treatment. That's where I need to be. And they might hear there's not a bed. Or, actually, from what you told me, that criteria, you actually meet criteria for outpatient. And even though people are not hearing exactly what they want to hear, we still hope that they're walking out feeling that we helped them, that we're guiding them in the right direction. And with the walk-in clinic, we have a lot of referral sources. So Chad Woodman, the drop cop, Officer Schoonover, I don't remember your other last name. They bring people in. And so people come in maybe kicking and screaming a little bit because law enforcement is involved. But law enforcement is involved and they want them to get help, just like Dan was saying. And so we kind of piggyback onto that and we try to steer them in the right direction. When people come to the walk-in clinic, so this is for any kind of substance, so alcohol, cocaine, marijuana, opiates, meth, anything. So specifically tonight we're going to talk about the opiates. People that come into the walk-in clinic, their drug of choice is opiates. We do give everybody information on overdose prevention. So we're providing information of where to get Narcan, how much it is if you don't have insurance. AIDS Resource Center is a place in Beloit where they give it out free. And so we make sure that everyone that leaves our office has this information because we can't help them if they overdose and die in the meantime while we're trying to get them set up with treatment. So this is just a little bit of data. So 2016, you can't read these at all. So opiates is the taller one. So this was 2016, like I said, we served 211 clients. Thank you, Vanna. We served 211 clients in the walk-in clinic in 2016. 46% of those clients identified opiates as their drug of choice. And when I say the word drug of choice, that's the clinical term that we use. It just means that's what they're using most often. And then the following one that was just a little bit over 80%, that's alcohol on your far left. Thank you. So this is 2017 data. So we served 191 clients in 2017. But our percentage of opiates for drug of choice went up to 51%. So we're seeing it in client. I don't think that that's really too shocking for anybody, but it's just it's nice sometimes to see stuff on paper to prove, okay, we really need to be doing something about this. So last year in July, we applied for the state targeted response grant to the opioid crisis. We applied for, I don't know, about $500,000. We got 124. With that 124, we were able to create a program called the Opioid Treatment Program. We call it OTP. In Rock County, we like to make up acronyms for everything. So we started the program. The money kind of came down a little bit slow, and the approvals were a little bit slower than we expected. We started our program on October 31st of 2017. And again, this is specific to people who have opiate use disorder. So we have served 30 clients since we began that program. One of our major goals was to have no overdose deaths of clients that were enrolled in our program. We've been successful. We have had overdoses in our program, but they were revived by Narcan. So I can't stress Narcan enough. Everyone in our program, this is a medication-assisted treatment program. We call it, again, an acronym, MAT. So everybody in our program, per the grant, has to be on MAT. So they're either on Suboxone or Vivitrol. I didn't put up the data of how many people are on Suboxone versus Vivitrol. We have more clients on Suboxone than we do Vivitrol right now, and it really just depends on the client's needs, their history. So some clients are better candidates for one medication versus the other. What else do I have down there? Oh, one major thing that I want to point out too. So last year, in July of 2017, we identified that the wait time for someone to get MAT, that life-saving medication, was 22 days. We were able to get that down 50% to 11 days. So people, and this is general, people will have to wait maybe 11 days. Our goal when we started this program was to decrease the amount of time that people have to wait, because people are on a wait list and they're overdosing and they're dying. And so we can successfully say that that has not occurred when people have been waiting to get into the program. Again, because we're providing information for Narcan. The services offered, so it's considered an intensive outpatient program. So they're getting psychiatry, medication management, counseling, case management, so helping them find a job, housing. Like Brandon said, he wasn't even getting food. He didn't have money for food. We're trying to get those basic needs met in the beginning of this program, and then people can start doing the therapy. I also added nursing support, so they're getting the medications. We do medication counts. Obviously, we're concerned about diversion of people passing off their medication to others. So we try to, do that. So we do med counts and UAs. This is our drug court program. So if you look at the very far left, in 2007, the green, can you point to the green for me, please? I hope he's not colorblind. Thank you. The green is opiates. And so if you look, 2016, I believe, is our latest data. Yes. 2016, opiates for the drug of choice has increased significantly. So in the little blue bubble, it says 2007, 12% of people identified opiates as their drug of choice. In 2016, it was 77.5%. So again, a significant increase in opiate use disorder. So additional efforts that we're trying to do, not only within Rock County, but engaging the community. Aaron talked about the heroin task force. So with the heroin task force, I have like our mission and stuff up there. That stuff is on the Facebook page if you want to look at that. And then there's 3 subcommittees that work together. Anybody can be part of these subcommittees. So we have people from many different agencies. We have people in recovery. We have parents, loved ones. Anyone in the community can be part of this. So you feel like you're assisting in this epidemic. AODA steering committee. Again, I have our mission statement up there. So we were focusing on overdose deaths and reducing those, increasing and expanding the capacity for MAT in our community. We've been successful with everything that we've written down on there. We've expanded sober housing as well, or been part of expanding. I can't claim all of that. Community needs, things that we still need to work on. Expansion of MAT. I just said we expanded, right? We need more. We need more. Buprenorphine or Suboxone and Vivitrol providers at a local community behavioral health or primary care clinic. We need buy-in from additional people. And I'm talking about like the primary care physicians. We need help because, again, we need to expand that MAT. Increasing the collaboration and partnership. So, I'm talking about the partnership that we have up here. It could always be better, right? I mean, we should always be trying to strive to be better. So just continuing to focus on that. CPS, criminal justice population, just getting people trained as well. Stuff like this stuff needs to happen. And I'm so excited that Aaron's role has been able to make this happen and reaching out to other people in the community. And so I'll stop rambling. So that's all I got. Thank you.
Thank you, Brenda. And finally, we'll hear from Sarah Bradley from the Wisconsin Department of Safety and Professional Services.
It's a long one.
It is a long one. I like DISPIS.
Like Rock County, the state likes acronyms as well. All right, as Erin said, I'm Sarah Bradley. I'm the Deputy Director of the Prescription Drug Monitoring Program. I want to thank Erin, Linda, and your colleagues for organizing this event tonight. I want to thank Daniel and Brenda for the work that you guys are doing every day on this. And Brandon, I want to thank you especially for being willing to get up and share your personal story. I'm here today to give you guys an overview of the Prescription Drug Monitoring Program and how it's being used to help prescribers make better informed decisions when prescribing controlled substances, and also review some of the dispensing trends we're seeing from that program. Wisconsin has had a prescription drug monitoring program since 2013. But a lot of the success that we're seeing now is due to legislation that was enacted last year, as well as the enhanced system that was implemented prior to that legislation, recognizing that there was going to be a significant increase in the use of the prescription drug monitoring database. So at a very high level, what is a PDMP? It is a system that all dispensing pharmacies submit data to. It goes into a statewide database, and then authorized users can tap into that database to get a more comprehensive history of prescribing for a patient. It then crosses the barriers of health systems and clinics, so providers truly have comprehensive information on that patient. The access to PDMPs varies by state. In the state of Wisconsin, our users kind of fall into 4 buckets. One is the clinical decision support tool, so that is the healthcare provider side where they're able to access the PDMP to help them make better informed decisions around prescribing. It's also used as a prescribing practice assessment tool. This is available to prescribers and medical coordinators to start to look at trends within prescribers to see where there may be opportunities for education and outreach. It can be used as an investigation tool by local law enforcement and by medical coroners and examiners. And then it's also used as a public health tool in terms of the data we provide publicly, but we also work with researchers to provide de-identified data. So nationwide, there are PDMPs in 49 states. Missouri is the one state that doesn't have a statewide database, but they do have a county database that's available to the entire state. So essentially, this is now a nationwide standard for how to address some of the prescription drug issues. Who can access those and requirements to access those vary state by state. In Wisconsin, as I mentioned, our system was first established in 2013, but the legislation that we saw recently has significantly changed the access to the PDMP. The Wisconsin PDMP is also connected to 15 other states that allows healthcare providers to have access to dispensing data for the bordering states and outlying states that their patients may travel to. And the Wisconsin PDMP is a nationally recognized PDMP for some of the visualizations and data analytics I'm going to touch on tonight. As Erin mentioned, the PDMP is housed at the Department of Safety and Professional Services. That is the same department that handles licensing of pharmacies and medical providers, so that's why it falls under that umbrella. We also support the Controlled Substance Board, Pharmacy Board, Medical Board, and then that can lead to Division of Legal Services and Compliance investigations and disciplinary actions. So the Wisconsin PDMP, the enhanced system, was launched January of last year. We have over 2,000 dispensers submitting data, over 46,000 healthcare users. And in the state of Wisconsin, the PDMP contains all data on controlled substances 2 through 5 dispensed in Wisconsin. So that's opioids, stimulants, benzodiazepines, and we currently get about 9 million records a year. As I mentioned, legislation is really a key component of the success we're seeing right now. Most significantly is that there is now a requirement that before prescribing a controlled substance, a physician must check the PDMP. Another change that came from the HOPE legislation, prior to 2017, dispensers were submitting once a week. They're now required to submit 1 business day after the dispensing. And then it also improved some accessibility for medical coordinators and for law enforcement. This is just a quick visualization of the impact that that legislation had on use of the PDMP. When it was a voluntary system, we saw about 4,000 queries a day. Once it became a requirement, that went up to almost 35,000 on a peak day. And then monthly, we were seeing about 100,000 queries per month. That's now increased upwards to 650,000 per month. And the graph on the bottom is what?
Number of queries.
Oh, thank you. That's the monthly queries. I was getting ahead of myself. This was the graph I was looking for. Another significant improvement that came with the enhanced system is direct integration into the electronic health records. So this allows one-click access for physicians when they're in the electronic health record to get the information from the PDMP. So that blue line on the bottom is showing you the percentage of our queries that are now coming directly from the EHR integration, rather than doctors having to go out to the PDMP website and log in separately. So that is something that we definitely see increasing. We're at about 30% right now of our queries coming from that, and we continue to have health systems who are integrating the PDMP directly into the EHR. So the primary piece of the PDMP is that it's a healthcare decision support tool. This is most of the image of the what you would see in the site. So over here is what a typical PDMP would display. It's simply a list of all the dispensing data. What the Wisconsin system does is right up here in this white space, shows a map of where that person lives, where their prescribers are, and where their dispensers are. As was mentioned earlier, interstate travel can be very indicative of prescribing habits. So that can give a quick visual if a patient is traveling long distances to get their prescriptions. This graph down here is a quick visualization of the morphine milligram equivalents that that patient is receiving daily. And those two static lines are the CDC guidelines of when overdose risk really increases. Oh, there it is. So that's the map, and then these are critical to the PDMP. Those are the alerts. Those are driven by data and also by user-led alerts, and I'll talk about those in a little more detail. So these first two boxes really give the user an at-a-glance summary of whether or not this patient has some concerning history that requires a little bit more time to review the PDMP data. We have 4 different types of alerts. The first are data-driven alerts, so those are data analytics that run in the background and let that prescriber know by putting one of those red flags on there if this patient has a high daily dose, if they have concurrent benzo and opioid prescriptions, which can increase risk of overdose events. We also have law enforcement alerts. Those are alerts entered by law enforcement of overdose events, suspicion of violation of the Controlled Substance Act. And then we also have prescriber-led alerts. So prescribers can enter overdose information, or they can enter detail about whether that person has entered into a treatment agreement. One of our huge successes is the user-led enhancements. We take a lot of input from our users to continue to make this system usable and valuable to the healthcare community. So that is where the prescriber-led alerts came from. The patient's panel gives a high-level summary of that doctor's most recent 100 dispensings and lets them know if there's any alerts for those patients, and also provides them with some high-level summary of their prescribing practices compared to other specialty peers. Law enforcement can use the PDMP to enter alerts about overdose events, both fatal and non-fatal. Those alerts are then, they generate an email notice to the prescriber, so the prescriber then goes into the PDMP to see the law enforcement detail. This also includes any suspected violations of diversion or intent to distribute. And that red banner then goes on top of the patient record so that future prescribers will also see that information. Law enforcement can also specifically request patient records as part of active investigations. And then lastly, I just want to quickly touch on the statistics. There's some handouts on the back table that summarize the last 3 years of trends. We also have a website, which is where most of that data was pulled from. So if you're working with task force and you're looking for some additional data specific to Rock County, you can pull that from our website. But at a very high level, we are seeing positive trends in dispensing. Physicians are becoming more aware of the dangers of prescribing opioids and also making better informed decisions when they're seeing that comprehensive picture within the PDMP. And this slide just gives you a very high-level overview. Those first three are those data-driven alerts for 2018. So this is really showing how physicians are starting to taper patients down from some of these medications. And then the last two are showing things like doctor shopping. Now that doctors can go in and see how many prescriptions somebody has from different providers, they can adjust that prescribing pattern. So with that, I will turn it back to Erin, and I think we're ready for questions.
Thank you very much, Sarah. So one of the important things about what Sarah was talking about is that we know that when the epidemic started, approximately 8 out of 10 opiate users started with prescription medications. So something like the prescription drug monitoring program, although it feels like it might be a very high-level instrument, it certainly has a huge level of benefit at any local level as well. So we are going to be moving on to the question portions. We have some volunteers who will be walking around and picking up your index cards if you have a question. And then what we'll do, like I said, is if we don't have time to answer everything, then we will be posting the answers on Facebook. Okay? Thank you, Neil. So the first question is for Officer Schoonover. Has law enforcement taken a proactive rehabilitation approach to the war on drugs versus arresting their way out? And this question is about the nationwide approach being taken.
I guess I can't speak at nationwide approach. I know that specifically for our department that arresting your way out of the problem is something that we kind of readdressed. We're more focused on treatment versus charges. Brenda kind of touched on it. A lot of times they go kicking and screaming into the ODA clinic when we bring them in, but there's always that agreement that we'll withhold charges when appropriate to try and get treatment, and we'll use the halo of a charge over somebody to force into treatment. We've had success with that. There's also setbacks with that. When somebody's not truly ready to kick the addiction, it can be a little bit more difficult. But as far as the nationwide approach, I know that the trainings that we go to and the discussions that we have at statewide levels, people are always looking for ways, new ways to approach the addiction and the opiate crisis. And it seems that statewide there is a big push towards dealing with people on a more personal level versus trying to arrest people and just put them into prison for what essentially we've identified as a disease now.
Thank you, Dan. I have a question here about drug court. I'm going to take this question and get it answered by staff that work at drug court, and we'll post a response on Facebook. The next question is for Sarah. Sarah, the enforcement of the prescription drug monitoring program, what percentage of pharmacies actively use it, and what percentage of doctors use the prescription drug monitoring program?
We are currently in a pharmacy renewal license period right now, and as soon as that period wraps up, we're going to conduct our next audit of pharmacies. In terms of physicians, we are still working with the Controlled Substance Board on determining how they will review the prescription drug data and make appropriate referrals to the med board or other prescribing boards.
Thank you. Brenda, how can a medical facility use what is called a treat and release diagnosis under the law?
I'm sorry, can you repeat the question?
How can a medical facility use what is called a treat and release diagnosis under the law?
I do not know that answer.
Okay.
I know that it's not best practice.
Okay. Thank
So
you.
we do not do that.
All right, but legally it's allowable? Is that
I honestly don't know.
okay?
Oh, so you're saying like if they go into the ER, Okay, so I guess if somebody's asking, can someone go into the ER with an overdose, be treated, and be released? Technically, yes, that's legal. Is it ethical? That's a different question, but technically, yes, it's legal. Well, that doesn't, so not everybody meets that criteria. That's a different question, too.
All right, so the next question is, how do we incorporate more medical providers and prescribers into these efforts and JM4C? So on JM4C side, what I would say is that anybody who is interested in joining the coalition or the heroin task force, it is open to anyone. We have requested different medical providers join us at the table for those. Depending on their schedules, it's kind of hit or miss. Most particularly, we have support from the MD1 through Mercy Health System, and for them, if they're out on a call, then they might miss a meeting. In terms of prescribers and medical providers, Brenda, would you like to also add to that? How to get people more involved in the efforts?
Talk to your primary care physician. I mean, it really comes down to the community pushing for this. I feel like agency-wise, we've been pushing for this, and I'm asking you guys to push, ask. We don't have primary care doctors that are willing to do Vivitrol. You don't need a special license. You don't need a special waiver like Suboxone. Any doctor can do Vivitrol. And so I urge you to talk to your primary care doctors.
Thank you, Brenda. Officer Schoonover, how can we ID an overdose? And if we recognize that somebody is in an overdose, how can we keep someone alive while waiting for the police if we do not have Narcan?
So initial things to look for would be like a change in the skin color. Generally, when people are in an overdose, what happens is the brain is like shutting down the breathing. So you'll see shortness of breath, you'll see like the chest rising and falling very quickly, changing to a purplish color. The best thing to do at that point, obviously after calling emergency services, is just start chest compressions. There are minutes worth of oxygenated blood in your system that will keep you alive just by doing chest compressions without breath. I know CPR is an important thing to be trained on, but if you're not trained, you're not going to do any harm by pushing on somebody's chest and doing the compressions to try and get it there. In most cases, we can have emergency personnel responding in those types of calls in less than 3 minutes, well within that time frame where you could just keep somebody alive without Narcan.
Thank you very much. Sarah, the question is, I am seeing my clients, say doctors, prescribing less but at higher doses, telling patients to split pills. Also, more clients combining drugs and more toxic homemade drugs with more negative efforts. Do you have anything that you can speak to on that?
I think that's where the medical coordinator role and access to the PDMP is where we're trying to do more of our outreach, because that is where a medical coordinator who oversees a prescriber can look at the overall trends for a prescriber. That medical coordinator won't have access to the patient level detail, but they can really start to work within their health system to look for physicians who may be outliers in terms of their prescribing patterns. So that's really where we're trying to look to the PDMP as an assessment tool as well to help those health systems, really kind of as an education step before we get to the point that the Controlled Substance Board is really looking at more referral type processes.
Thank you. And then there is another question on this card asking about new ways for treating chronic pain. I am going to see what I can do about getting a medical provider, to answer that question and post it to Facebook. Brenda, how many beds does Rock County have, and how quickly do they turn over?
So through the AODA walk-in clinic, we can fund people for treatment. We actually have contracts. We don't have any in-house detox or residential. So technically we have 2 detox beds a day at Tellurian and Madison. However, we would not send people to detox unless there was a significant plan with it, because the likelihood of somebody going through detox, coming out, they're more likely to overdose and die. And so we need a plan in place, and that's where sometimes the wait comes in. Residential beds, we don't have a fixed limit. It's kind of first come, first serve. We have 3 residential agencies that we contract with. Pregnant women get priority. So if somebody is pregnant and they come into the walk-in clinic, we are very clear with them that they're on the top of the list. And when we call to make the referral, they always bump the other people down who are not pregnant due to NAS. Sorry, neonatal abstinence syndrome.
Thank you. The next question is for the entire panel. If you could just keep your responses brief, we'll go down and everybody can answer. What is your opinion or facts that marijuana use is a gateway drug prior to using opiates or heroin? Brandon?
It is my opinion or my personal perspective that marijuana is not a gateway drug, but I also am not a scientist or a doctor, so that's just my opinion.
Again, as long as this is my opinion, I think marijuana is clearly a drug that most people start with. Given the trend over the past 10 years in law enforcement, we have kind of identified prescription pills as the new gateway drug. I think it was very clear during the DARE days that marijuana was the gateway drug that we grew up with, and I think it shifted to the new prescription pills.
In terms of the PDMP, we're only collecting data on monitored controlled prescription drugs, so it's difficult for us to make any sort of correlation between illicit drugs and prescription drugs with our data.
I definitely agree with Dan. And I also believe, so if people are smoking marijuana, they have a dealer. And so, and again, this is my opinion, not Human Services, so Brenda's opinion. People have a dealer, so they're already connected to the drug world. And so through friends of friends of friends, you start trying different things. And so do I think that it's necessarily the gateway drug? No. I actually think that your friends are your gateway.
Thank you, Brenda. Sarah, do dentists report to the PDMP when they prescribe?
Yes, any prescriber, anyone who has the authority to issue a prescription submits to the PDMP and also is required to check the PDMP.
This question is not on the card, but what about veterinarians?
Veterinarians' dispensings get submitted to the PDMP, so if the DEA is investigating drug diversion, they can collect information about dispensings from a veterinary. Veterinarians do not have to check the PDMP when issuing for non-human patients.
Thank you. I read something about opioid use impacting senior citizens. Can you address the variety of age brackets impacted by opioids? I believe I'll give this one to Officer Schoonover.
Thank you. I guess from a law enforcement perspective, when we look at the age brackets of opiate use, even 3 years ago we used to say that it was very uncommon to find somebody under the age of 18 that was on any sort of an opiate addiction or that we were identifying. I think recently we've identified several different brackets that kind of like we divide 55 and above, and there's that clear bracket between like the 24 and 40-year-olds, and then we have the younger brackets as well. I can't specifically state that there's a bigger problem in the older bracket versus the younger bracket, but I would say that we are getting overdose responses across the board from anywhere now between 16 years of age and going all the way up into that 65, 70 years of age. A lot of times, I will say a lot of times as you get older, some of the opiate overdoses have other medical issues that go along with it, either through some memory loss stuff, forgetting that they took medication, taking too much accidentally, which can kind of cause numbers to be higher.
Thank you.
And the Wisconsin PDMP actually has on the public stats dashboard breakouts by age, so you can look in terms of prescription drugs, how that is distributed by age and gender.
Thank you. And also, I want to say that if you know of somebody who may have memory issues and they are being prescribed an opiate-based medication, Janesville Mobilizing for Change does have timer cap pill bottles. You can get the pharmacy to print out a new label, and the cap on top will tell you the last time that it was opened, so you can keep better track of when the medication was last taken. The next question, oh, and those are free. So if somebody needs one for a family member, for themselves, they can contact us and we'll give them out for people for free. The next question, some communities are suing the drug company for the misleading info that OxyContin was not addictive. Are we? So I think that this might be an important question, so I don't want to necessarily wait till Monday. If anybody knows the answer to this. Oh, we have some answers in the crowd.
Yeah, Rock County, with counties that are coming together, and Rock County is one of those counties.
Okay, so what Emma said was that Rock County is one of the counties that are coming together to make that lawsuit.
We actually have Kate Lester here. I think that she would be a good.
Sure.
There's an effort coordinated through Wisconsin Counties Association to initiate lawsuits on behalf of the counties. This is in the very beginning stages, though. So there's not, it's the beginning stages of pursuing potential litigation against pharmaceutical companies. And Rock County the county board passed a resolution to
Okay, so what Kate said was that the county board did pass a resolution to participate in a lawsuit against pharmaceutical companies, but that it's in the very beginning stages. So, yes?
This is actually, I think, our second time around with looking at suing pharmaceutical companies, because it was several years ago when it was a reporter from Milwaukee who actually found out and brought to light that there was a problem with Purdue Pharma, which brought about a national case, and they were sued at that time. So we were involved at that point. It's actually Wisconsin bringing that to light, and now I think it's our second time through of going through this on a much more local level.
All right, thank you guys. We appreciate the help with that question. The next question is for Brandon. Brandon, can you tell us about your relationship with your parents while you were using and how they helped see you through?
Yeah, absolutely. So during the time when I was using, I probably could tell you that I saw my parents in that 4 years that I lived in Milwaukee. I could probably count on both hands how many times I actually went and saw them or they came and seen me. And that goes for all of my family. I didn't come home. I pretty much stayed there. There wasn't a lot of moving around. But they always, whenever I did need them, they always did come and support me. That doesn't mean that the first time that I relapsed, I was living with them, and my dad actually told me to leave. So at times, they had to be a little firmer with me. But when I made the decision to get help and to do some other things, they were always there for me. They always had my back. And right now, today, I couldn't be happier with the relationship I have with them. I gave this speech last week, Tuesday, and they came. And they tell me all the time, they tell me they're proud of me and that they're always there for me. So I think that's one of the biggest things that has helped me through my sobriety is having my family, my wife, even her parents have been great. So
Thank you, Brandon.
Yep.
When you think about the programs you would like to implement in partnership with local health providers, clinic, hospitals, emergency departments, insurance plans, what do these look like? And I believe I'll have Brenda answer this question.
Sure. So there's something called a hub and spoke. And so what we would like is to have the hub, so people are coming in and they're getting treatment, and right in the beginning they need a lot of care. And then after, so like I'll use Brandon for an example, he's doing really well. He's been active in his recovery, and he's been able to stay sober because he's been active in his recovery. But he's continued to see a psychiatrist. He's continued to see someone who's providing him support, medication support, emotional support, guidance. So if we can find people who are willing to do that kind of after piece, that's what we would like to see. So it's kind of like other agencies who are maybe more well-versed in it would help somebody right away when their life is completely chaotic. And then once they get more stable, then we would start to transfer them out to other people who just see them once a month or once every couple months. So that's kind of the idea of how we would utilize primary care or other physicians.
Thank you, Brenda. Sarah, how does the PDMP protect HIPAA rights for individuals when there are so many eyes looking at the medical records?
So patient confidentiality is in state statute as well, and users cannot access the PDMP unless it follows those state guidelines for when they can access a record. So a physician can only access a PDMP record if they're actively treating that patient. And there are extensive audit trails in the PDMP system, so we as administrators can pull reports to find out exactly which patients were looked up by a user, or on the reverse, look up whether or not a physician did look up a patient prior to prescribing. But it is protected by both state and federal statute, and we do have extensive audit tools. And the user access to the PDMP is directly tied to the license, the medical license. So if the license is expired or revoked, their PDMP access is also revoked at that time.
Thank you, Sarah. Officer Schoonover, what percentage of officers in Janesville are trained? What kind of training do you get? Is there regular updating of best practices in regards to opiates, heroin overdoses, etc.?
I guess, is the question specific to response to overdoses, or?
It says, what kind of training did you get?
Well, for my position in our street crimes unit, we get specialty training in addition to whatever we got at a patrol basic level. A patrol basic level, there are kind of updates that go throughout the year. Officers kind of see anything from Narcan administration amongst how we are going to administer to another officer when we're testing the opiate. We also have basic instructions from our emergency responders, paramedics, fire department, and MD1 on how to best start treating somebody that we come across that might be in an initial overdose or crisis. But the levels of training are not the same, and the levels of training that we receive throughout the year can differ depending on what your position is at the department.
Okay. And how has the crisis affected the other responsibilities of law enforcement? Has staff of JPD increased as a result of the crisis?
We do the best that we can with what we have. Our staffing numbers have maintained relatively the same over the past, I believe, 12 to 15 years. Call volumes increase, but we keep going at it.
Can I add that JPD has drop, and so that's something that no other agency around us has, and so Janesville has that going for them. That so maybe you haven't increased how many police you have in the force, you've increased drop and the people that are involved in that, and so I would say that's how you're addressing it as well.
Thank you.
Brenda, how can we go about expanding MAT options?
So if we're talking about buprenorphine or Suboxone, same thing. Physicians need to get a waiver. I believe it's 6 to 8 hours online. It doesn't take too much, but they need to prove that they know what they're talking about, and they need to prove that they know how to prescribe safely. So if we could get more physicians that are willing to do that, more physicians that are willing to prescribe Vivitrol. Again, if we do the hub and spoke model, we can get people stabilized, move them on just for medication management where a physician can treat them. Did I answer that?
All right, and the final question is there any way we can volunteer to help people in crisis and their families? You must have read my mind. It was, where did it go? Right here, how to get involved. First, you can join the Rock County Heroin Task Force. We meet monthly. We have two different subcommittees, the Neonatal Abstinence Syndrome Committee and the Opioid Involved Death Committee. The Neonatal Abstinence Syndrome Committee focuses on how do we prevent a pregnant woman, a woman who may become pregnant from using opiates that will later affect an infant. And the Opioid Involved Death Committee is where we schedule our Narcan trainings. Right now we're working on a support group for families that have lost somebody to the heroin epidemic and opiates. And also we're working on doing some movie screenings of a show called Warning, This Drug May Kill You, which is an HBO documentary that will be showing at the end of May and the beginning of June in Beloit and Janesville. Another way is you can learn how to administer Narcan. So we know that the Surgeon General has asked for as many Americans as possible to carry Narcan. And coming to a Narcan training is a great way to receive that Narcan. At the end of the training, which lasts about an hour, you do receive 3 doses of Narcan if you are a concerned citizen, and you receive 5 doses of Narcan if you are somebody who is actually using opiates and might have a higher need of it. The upcoming naloxone Narcan trainings are May 2nd in Edgerton at Vanny Go. It's being held by Healthy Edgerton. And then we're having one on May 15th in Janesville at Fire Station 1. If that's something you're interested in attending, I will tell you the last time we had it at Fire Station 1, parking was an issue, so come early. And another way that you can help is you can attend ACE interface training. That's going to meet May 17th at 6:30 right here at the public library. What this is we have found, research has shown that children that have high levels of ACE scores, which are adverse childhood experiences, are more likely to misuse opiates when they are older. So one of the grants that we have focuses on how to reduce trauma and try to get those ACE scores down. So if there are no further questions, I would, yes. Those are both at 6 p.m. Yep.
And do they require pre-registration?
They do not. So for the Narcan trainings, you can just show up, as well as the ACE interface training. Are there any further questions? All right. Well, yes.
Where is the ACE interface training location?
Here at the Hedberg Public Library in the program room. All right. I will turn it back over to Linda. Thank you guys all for coming.
Well, thank you. I want to thank our panelists, Brandon, Officer Schoonover, and our visitors from Wisconsin Deep SPS. And Brenda, thank you all very much, especially to Aaron, our co-sponsor for this panel, the Janesville Mobilizing for Change. You've given us a lot to think about, some of it quite inspirational, Brendan, and hope for the future, but concern about ways to get involved. And thank you all for being interested and concerned audience members.